And we are back. My name is Anna Maria Mazzieri, and after a couple of years of sabbatical, Massage Matters is back. Although we are now called Touch Matters. Why? Well, we have decided to expand to a wider audience with more content, more education, and as usual, more irreverence to the status quo of our industry.
Thank you, Anna. Yes, indeed. Welcome to Touch Matters podcast, part of the Physio Matters group. As well as a new name and logo, we have new voices as well to add to the dulcet tones of Anna Maria Mazzieri, including myself, Matt Phillips of RunChatLive.com, and members of the ST school team, Sarah Jones and Imi Tester, both evidence-informed soft tissue therapists with a wealth of experience to share with you all.
We start this series with an absolute dynamite of an episode. Myself and Matt are joined by very special guests, Roger Kerry and Kenneth Young, two of the lead authors on a recent published paper I was very privileged to be involved with, called The Modern Way to Practice and Teach Manual Therapy. The paper was a collaboration between 16 authors from different professions, with other leading authors, including Steve Vogel and Vasislis Georgopoulos. So put your headphones on and enjoy this chat.
Welcome, everybody. Thanks very much for listening to this podcast. Very excited. My name is Matt Phillips, creator of RunChatLive.com, and you're listening to Touch Matters, but more importantly, a modern way to teach and practice manual therapy. So the best thing I can do now probably is introduce three of the authors on that paper, and then we'll get to know the paper in more detail later on. Sorry, Anna Maria, but I've got to start with Roger Kerry because I've been dying to meet Roger for years. So this is, just remind me you're here later on, Anna. Roger Kerry, the paper. I'm going to introduce you first of all. I want you to obviously talk about yourself for people who are not aware of who you are and what you do, but 26,000 views in 6 weeks and featured best article of the quarter. Pleased with that? Satisfied? Surprised?
Yeah, all of those things. But listen, this is Ken should deserve the sort of accolade here. He put so much work in over the last final few articles. So it really is. It's teamwork. It's a massive team thing. But Ken did that. Yeah, really quite pleased because it's taken a long time to get this published, and it's been a really interesting journey with very again, sort of expected insights into the professions, and yeah, it's been a colourful journey, but we got there. Yes, please, good, great, thanks Ken, thanks everyone.
Amazing. And there's going to be, isn't it, sharing with each other, saying, oh no, it was you. But I think that's one of the things that shines through the paper because there's such a massive collection of names on there. I'm not going to try and go through all of them, but just to, if you are listening to it, it is a free open access to this paper. You can get it. Links will be able to be put into the show notes and everything. And today we have got Roger Kerry, Kenneth J. Young, and also Anna Maria Mazzieri. But there's 10 other people who I'm sure I'm not even going to start. I'm looking at the names. I'm not going to even try and read some of them out because I would just get them wrong and embarrassing. But just before we move on to the other two people who've got here today, Roger, why you? What made you? I'm sure you're a busy man. What made you want to get this rolling and put it together?
I'll take the sort of get out approach, so I don't get as much flack because I approach it from an educational perspective. We got to, every year when you sort of running programs and stuff, you have to sort of make some decisions about what you teach, what you don't teach. Should there be massive shifts in the program content? Is it time to get rid of this? Is it time to bring in that? So we were forever sort of making all those things and looking at the evidence to influence those decisions. And this, some years ago, we had some program discussions about what do we do. We sort of really ramped back on things like electrotherapy and stuff like that, and then manual therapy came up, and it's like, what do we do? Is this something that the evidence still supports? What's happening in clinical practice? And we started to just review the evidence and sort of change our teaching a little bit on postgraduate and undergraduate stuff, and we just naturally fell into this sort of what I like to think is an evidence-based, evidence-informed way of delivering our manual therapy thing. And then we've got chatting. So that was with two of my colleagues, Vaz and Ed, who are on the paper as well. And then got chatting with Ken from the chiropractic professions, and then Steve Vogel, who's at the University College of Osteopathy, and sharing some thoughts about what other people are doing. Then Anna Marie came on board as well, and it seems to be this line of subpopulation of each of those disciplines sort of thinking on the same lines.
And it was also the right time, isn't it, Roger? I think it all came when you also guys did the I think it was an Eventbrite session, and it was just after COVID, after a lot of people were being exposed so much more to wider access to knowledge, and lots of professions, like for example ours, that have been exposed to the importance of evidence-informed practice. And those thoughts came at the time where there was the need for change, where actually we realized that the people that we were teaching, the clinicians, needed to be served better at education level. I think it all came at the right time. I think at the same discussion, having had 5, 6, 7 years ago, it wouldn't have had the same impact that it had. I think it was the right time. People now understand differently.
That's so interesting. We've said that a few times, how, I mean, COVID was obviously a disaster and is still an issue for many, many, many people out there. But one thing in healthcare it did do is kind of start enforcing, because sometimes you needed enforcing clinicians to start talk to each other and supporting each other. There was questions where we needed, should we wear gloves? Do we need a mask? Can I go back? And it also just interdisciplinary as well. Suddenly physios were talking more with soft tissue therapists, because there was like, we can do it, but you can't, but can you? And it's so I hate saying it, and I feel guilty every time I say it, but there were benefits from COVID. It kind of fast forwarded a little bit healthcare, even online consultations, which a lot of us had to get involved in, suddenly made us realize, some of us kind of knew all along, but made us realize how much we can help people without putting our hands on them. Okay, we're not taking away hands, but how important communication and listening and just being there and supporting was. And that, I think, gave a little fast forward button, a much needed fast forward button to healthcare. Anyway, let's just not get too carried away with the actual details yet. Kenneth, could you tell us a little bit about yourself for listeners who aren't aware, and why you got involved in the paper?
Yeah, thanks, Matt. You can call me Ken. My background is in chiropractic. I qualified in Los Angeles a long time ago, and did extra training in diagnostic imaging. And I have spent most of my career teaching diagnostic imaging to chiropractors. And then moved to the UK. So I've also spent some time in Australia. Moved to the UK after I got my PhD in 2018. And became a senior research fellow here at the University of Central Lancashire. And basically, when I was invited to have a discussion with Roger and maybe a couple of the others, it's hard to remember because it was 2.5, 3 years ago. I mean, this has been quite a process. When the idea was pitched to me about a transdisciplinary approach to manual therapy, incorporating all the new and developing ideas about how it should be taught and practiced, which was something that I had been heavily involved in here at UCLan, pitching to the people there that, there are far more similarities than differences between these 4 major manual therapy professions, right? The soft tissue therapists, the osteopaths, the chiropractors, and the MSK physiotherapists. We have far more in common than we have different. And we should be encouraging collegiality and much more collaboration between these professions, because in the long run, that's going to benefit patients, right? Patients right now are presented with this marketplace of ideas, which has upsides and downsides. But I think there are more upsides to getting the manual therapy professions talking and working together to present a coherent picture of the approach to manual therapy, which has demonstrated benefits and that it has earned its place in healthcare, you know, alongside medicine. And that's the other element, is that we also need to be collaborating better and communicating better and teaching this to our students about how to talk to the other manual therapies and to people in the medical profession. And the other long-term goal that I personally have in mind is a sort of expansion of the idea that the NHS came up with as well, and that's that first contact practitioner role, that there should be an expert in musculoskeletal care in every GP's office. And now, whether that's a soft tissue therapist, a chiropractor, an osteopath, or an MSK physio, I think the training is fairly good, and we should, you know, upskill to a uniform standard and provide that service, especially seeing the national crisis with GPs that's occurring now, and it could really relieve some of that burden. So it's really the transdisciplinarity of it that attracted me, and I thought that a lot of these elements that we began talking about then have been, you know, popping up in the literature, but this was the paper to bring them all together. And it's really, now I know we're getting into the Mutual Admiration Society here, but it's really Roger that's the intellectual driver behind all that, you know, and he absolutely scoured the literature and got so much support for all the statements that are in the paper, that that was one of the criticisms that we got from the reviewers, was there too many references, you know, and you know, Roger's response rightly was, hey, that's the point, you know.
Yeah, exactly. Amazing. You know, I'm listening to you. First of all, I'm just admiring your use of the English language. It's beautiful. And secondly, yeah, I'm excited for people who haven't looked at the paper yet, who are going to listen to this podcast and then read the paper, because it's almost like the abstract should be a podcast edition, because by listening to you guys, you're going to get such a larger insight into what's behind the paper, the kind of people involved in writing it. So if you are listening to this podcast, then don't go and rush off and read the paper now. Listen to all of this and then have a look, because I think it'll almost like help it make much more sense. Thank you, Kenneth. Anna Maria Mazzieri. I mean, I know you very well. We work together on a lot of occasions. What Ken has just said must be music to your ears, and I've got no doubt that's why you jumped in feet first to get involved in this.
Indeed. To me, well, for the first time now, we are, excuse me, we are discussing manual therapy not as a modality, but as an approach to person-centered care, through with the potential use of touch in the form of manual therapy. Manual therapy is not, chiropractic is no modality, osteopathy is no modality. Or soft tissue therapy, massage is no modality. We need to stop thinking them as a modality. And I think this paper, the proposed model, I think is quite clear with that, that actually what Ken and Roger were saying, that standardized approach to person's care is the same. Does not matter what professions you are or what level of qualification you have. Then we all move towards our bias in terms of manual therapy, and indeed bias towards what type of hands-on they prefer. To me, I mean, you can imagine, for all the massage therapists out there, you know that my background is massage therapy. I then are graduated in sports therapy, but I still very identify myself as a soft tissue therapist, because I do think I do value vocational. I am a strong supporter of vocational or good vocational training, because I think there is a place within modern healthcare to have clinicians which are vocationally trained at a certain level. So for me, never, you know, been a evidence-informed practitioners for years, but being able to, when I was offered to be part of this, I mean, it was an honor to just say the least, especially, people like Roger and Ken or Steve that I read papers of, all of a sudden, oh my God, I'm co-author of that. The process of it was so interesting to see the input of people and how the paper grows and how these ideas then takes their own, they become, so start with an idea, then they become, with everybody input, something bigger. So I felt very, very, very privileged. But what to me was so important, I cannot stress it enough, we have soft tissue therapists written onto an academic paper of good quality. And that is important because then all of a sudden we are raising the benchmarks of what people should be aligned to, but also that we are recognizing that in this modern healthcare, there are other professions that might not be regulated, but patients, clients, in fact, I don't call them patients, clients approach for their care. So we can forget about it and say, oh, no, massage or soft tissue therapy is not part of our care. Or we can actually embrace it and raise the standard so that we provide a depth of approach to care which reflect the depth of the society we live in. So to me, that was really important. And plus, as you can imagine, everything, the content-wise is what, we've been teaching. And the amount, the precise, the work through that literature and the papers that have been, fully, the literature review is fantastic. That's why I gave it to my students, because here we are. So that's, it's such a good quality educational resource for any in education.
I think that's a good message for everybody, is good things don't come quickly. We kind of tell it to our patients all the time, like there's no such thing as quick fixes, there's no one size, and yet when as clinicians, we jump straight down at the latest modality that comes up thinking this is going to solve my life. And we don't so often clinicians don't practice what they preach. We really show great empathy with our patients, and we're really kind, we give them time, we listen, we put our hands in front of our mouth so we don't say something quickly. But when it comes to a clinician talking to another clinician, especially on social media, we're total, I won't use that word because I'm not sure whether we're allowed to, but we don't have any empathy. We're not patient. We don't encourage each other as clinicians. It's all so much a battle. So the more I hear you guys talking about I can't even say the word now, but Ken said it so well, transdisciplinary. What a surprise. We know that's what helps a client get better and a patient get better, a multidisciplinary approach which fits them, which might be different on a different day of the week for the same person.
Only if everybody set the same standards
exactly.
of understanding. That's the problem, that we're not.
So, yeah. So that I think before we move and look at the paper, just a little, what I've got from you three already, and a big message I think for the listener is, don't look for quick fixes on how you're going to deliver your services better. There's a paper here which took since COVID to write by people who are far more intelligent than any of us, and they've finally produced it, and the answers are in there. And you can't just get away with reading the abstract, you're gonna have to look through the whole lot. But yeah, so many answers are in there, and you'll be nodding your head as you read them, which I think is a segue into getting into the actual paper itself, with some questions I've got for all three of you. So we've kind of touched already on why this paper was needed, but I'm interested in dividing it down into something which you guys kind of mentioned quite a lot of the time, some keywords which you mentioned, which is talking about clinician-centred palpation. I'm going to divide these up into the three as you mentioned. Maybe we could talk about them a little bit more to explain the relativity in the paper. Patho-anatomical reasoning and technique specificity. So maybe if we start with the principle of clinician-centred palpation. Back to you, Roger. We're just going to go in order so no one feels embarrassed or.
Yeah, no, that's absolutely fine. These, so try to look at the evidence to see what we talk about these pillars of the traditional manual therapy. So we sort of build this concept called traditional manual therapy in order to play the sort of modern version off against. And these sort of three pillars emerge from the literature. And again, just in terms of acknowledgements, it's really important to say that Dave Evans, who's also an osteopath, was extremely instrumental in sort of packaging and sculpting the way we sort of thought about this, and some of the terminologies really helped with. And we all challenged each other so much as to what these things meant. But I mean, again, like you said, Matt, people reading this will be nodding along, because there's nothing. I mean, this is just a sort of, there's a lot of common sense in this way. So essentially, the literature is sort of strongly pointing towards the idea of us as clinicians trying to perceive something like, say, for example, resistance of a joint movement or something like this. You know, it's not that there's no evidence to support that, it's that there is evidence to say that, you know, even very skilled humans have difficulty in sort of reliably and you know, perceiving stuff like that. And therefore, what role does it play if everybody's doing something quite different, perceiving, communicating things quite different? So when we assess or manage, treat tissue, soft tissue, joint, whatever, and we're thinking we're getting this information from that, or the literature challenges that. But what is a little bit better is you know, what we sort of person-centred responses, if you like, to touch and assessment and management. So, you know, reproduction of symptoms or feelings of discomfort or things like that. That sort of thing seems to hold up better in the literature. So that pillar is really saying, well, let's move away from this idea that we think we're really good, and that actually the more skill, the more courses you go on, the more skill you get, the more you think about this, we can differentiate between this grade of movement and blah 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 or whatever. Let's move away from that. But what we do seem to be able to do is understand people's musculoskeletal dysfunction and its symptomology by the use of touch, and that's a valuable thing. And just before we move on to the other pillars, the sort of broad thing that underpins this is we've seen from, so we looked at the, you know, randomized control trials, systematic reviews of RCTs, and put them all together. And there's a sort of paradox in here. I think it's probably a paradox, probably not quite, but something like that. So manual therapy is said, we all sort of think it works, but that is also, you know, supported by trial level evidence. So there is therapeutic effectiveness, but it doesn't seem to rely on these old constructs of traditional manual therapy. So the effectiveness of manual therapy doesn't rely on the clinician's ability to perceive a particular type of resistance or something like that. So that's really what we kind of meant. I don't know if Ken and Anna Maria have got a different interpretation of that, but in my simple mind, that's what we meant by clinician-centred palpation or assessment or whatever.
That's great. And we will get Ken and Anna Maria's thoughts on that in a second, but I think the important point you raised is, because I know what people are like out there, again, because of the internet and social media, we're saying basically the mechanism for manual therapy is under scrutiny, but we're not saying stop doing all manual therapy, because people, as soon as you say, oh, manual therapy, there's no evidence for this, go, oh, what, you're telling me I shouldn't use my hands?
Yeah.
And that's not what we're saying. This is not Twitter, people, okay? This is the Touch Matters podcast. And we're not doing that 50-50 kind of, you know, polarized debate thing. It is still valid. And I first heard Paul Ingram saying it, but if we know how something works, we can make it work better. That's the kind of the t-shirt to wear. Anyway, over to you, Ken, on the subject of, clinician-centred palpation and how that formed a part in your paper.
Well, what we're talking about is battling against history and tradition. And, you know, those have an important place in the human psyche, and they're powerful drivers of behavior sometimes. I think personally, I was born without that gene, because I've railed against doing anything because that's the way we've always done it since I was a little kid, actually. And so the idea behind this paper is basically evidence-based practice. Now, that's a common phrase. It's everywhere now. You know, since 𝐸𝐴𝐾𝐻 introduced it or defined it back in the 90s, it's really exploded. And there has to be a reason for that. And the reason is it fits in with science in the larger picture. So science is all about developing new evidence, new methods to get better evidence, refining evidence, and figuring out, at least in the realm of medicine, what is real, what works, and what doesn't, what's inert. And so that idea battles against the history and traditions, particularly of chiropractic and osteopathy. And in chiropractic, that profession has been at a crossroads for about 30 years. And we've made a few halting steps in a few different directions, to tell you the truth. It's a time that's still, there's still great friction, and we're still working through it. But ultimately, what's happening on the national and international stages in terms of healthcare is that evidence is being demanded for effectiveness and cost effectiveness. And that needs to be, the way that can be supported is through research. And increasingly, that research needs to be more and more rigorous. And we're developing new methods on how to do that all the time. One of the hot areas there is just to put an example out, is developing a good sham or a control group, a control intervention for spinal manipulation. Because it turns out it's hard to fool people into thinking that they've received spinal manipulation when they haven't. So that's an area that still needs a bit of development, so that the genuine effects, the mechanism of action of spinal manipulation, can be better defined and better understood. So in terms of clinician-centered assessment, I mean, I think clinician-centered anything in healthcare means you're approaching it incorrectly, right? And I thought that was a great phrase. I don't know, Roger, if it was you that came up with it or if it came out of the group discussions or whatever, but it's just, it really encapsulates the idea that, well, I know what I'm doing because I trained as a chiropractor and I have all the traditions. I understand what happens with chiropractic, and so I'm going to do it that way, the way that I was taught. But of course, we need to evolve as new evidence comes about. Now, in the paper, we mention a couple of examples of clinician-centered assessments, and one of them is my big hot button issue, and that's routine imaging, right? So that routine use of ionizing radiation, which is demonstrably harmful, even at low doses. That's what the best evidence says. And in addition to the potential pitfalls of the ionizing radiation itself, there's now evidence gathering that early imaging in the course of an issue, a problem, a medical issue with somebody leads to worse outcomes. So there's a dependence on the imaging that, oh, this is going to sort out my issue because I'll know what it is, and then we can know how to fix it. And it turns out that especially low back and neck pain, these are not easily fixable things. They're probably not fixable at all, but they are certainly manageable, and they can be, the quality of life of somebody with low back pain can be improved often with the use of manual therapies. So imaging everybody on a routine basis it's good for the clinician because it gives them something to talk about, a story to tell the patient, and it can be potential tool in a business model, frankly. But the evidence isn't supporting the use of routine imaging on patients. So that, we also mentioned the search for patho-anatomical lesions and asymmetries. And again, from the chiropractic perspective, this is the term in chiropractic is the subluxation, which has a variety of definitions. The profession has not agreed overall on what it really means. The very traditional definition of a subluxation was a bone out of place in the spine, pressing on a nerve, and then creating a problem with the end organ of that spinal nerve. And again, that hasn't held up under scrutiny either. And yet it still exists out in the wild world there. So clinician-centered assessment was definitely something that needs to be looked at hard and reassessed. Is this useful, again, for the patients? It might be useful for the clinicians, and they might be able to spread their word of their system or whatever, but is it really the best that we can be doing for patients?
In fact, I would go a little bit further with imaging to say that often for what we talk about routine imaging, often, we discuss about manual therapy, there is no needed. I would prefer to give manual therapy than to refer people for MRIs, especially knowing it's not that data is not supporting it, it's actually there is data to support the fact that they can have a 𝐻𝐸𝐵𝐞, they can create an 𝐻𝐸𝐵𝐞 message, and that for me, that's what I want to avoid, unless they're deemed necessary. So there are, we're talking about different reasons, but I would go, as I say, I would push it further to say, actually, we need to be careful that we're so careful not to use manual therapy because we are worried of making people dependent, but then we don't think twice about referring people for MRI or supporting MRI when they might not necessarily be needed, and that is more dangerous. And I preempt your question though, Matt, so I'm going to go in with a clinician assessment because palpation, but stop me there because otherwise I'm going to waffle, because this is something quite that I'm quite interested about, especially for soft tissue therapists. We touch people, our touch is different than a manipulation, because ours is dynamic, sustained touch is a different level. It does not have to be specific. We know that, but this is where, to me, the argument of the person-centered per patient versus the therapy-centered per patient in the paper is presented really, really well. Evidence is consistently telling us that we can reliably palpate probably, but we cannot put any meanings behind what we palpate. And this is, for massage therapists, is so important. Yes, I know that you touch, I know that you feel the difference. Don't put any meaning into the difference, because I might feel tight as whatever you say in English, my muscles might be very tight, but I am not stressed, I've got no injury, I have no problem. But and in fact, how often the client will say to us, oh, doesn't it feel tight? And actually the tissues, they don't feel that there is a lot of resistance, as you would expect. But do we have to even go down that discussion? We can just say to the client, what does it feel to you? And validate what it feels for them without actually having to put a patho-anatomical meaning behind it. So my waffle is really that we need to change how we use and see palpation. I love what Kenneth said very eloquently. I pick up from one of Mazzieri's paper, where he talks about the body as the pivot point for stimulating, facilitating therapeutic alliance. And this is what, to me, touch in any form for certain people at certain times is the pivot point to start that communication, to start that sometimes that pain literacy, to start that helping them to make sense of their pain, their issues. However, and this is a little bit of my contradiction a little bit. I know that we talk about there is no need for specificity, but I also think, what do we mean for specificity? Because there is skill in touch. There is skill, not, oh, I need to do this particular touch for this particular problem. But the way you touch somebody, touch, we know that communicates and evokes emotions. So the way I touch somebody can make a difference to how they perceive that experience. And that's what it's all about, is an experience. So yes, to me, there is specificity and skill set on how we touch. And we, on the paper, we do say that. In fact, on one of the case studies, you know, that the most important part of it is actually how we hold the person. And also in massage therapy, or when we work with the long dynamic touches, does the person benefit or enjoys a more light touch, so a more affective, see tactile, firing touch, or do they prefer a deeper touch? But that's why it is clients' preferences. What is making them feel better, or how can they gain the most out of that experience? So while we can say that there is no skill set, I will say there is skill set for touch, but not the way we think there was. And also the person-centered palpation, we should not be seen as useful to identify dysfunctions or useful to identify people in pain, or is used to communicate. Sometimes it can be like not a benchmark, but a monitoring for symptom modification without putting the meaning into it. What is very important, that we cannot reliably say what we are feeling and what we are not. And that's very important, especially for massage therapists. It's something that it's okay, you know, we need to be clear with that, and it's okay not to put meaning on why somebody feels that. And it's important that we follow now the evidence, not because it tells us that we were wrong. Evidence is telling us where we go next.
Great points. There's so much in there to unpack. One thing that I'm thinking, and I think now is probably a good time to address it, is, I think maybe you mentioned before, I think Kenneth opened up with the fact that when the publishing of this paper was announced on social media, there were people who kind of came out. I mean, there were professionals at kind of disagreeing with stuff, and they've devoted their careers to it. But they did have a point where they said, whoa, guys, you're calling this the modern way. How dare you? How dare you use the word modern? This isn't modern. I did this in 1995. And I remember, and even as I'm listening to it, and this is going to lead to a question, I promise you, but for me personally, and we've all had different journeys and who we've kind of come across and helped us, and the shoulders we kind of stand on. But it makes me very much think of the first time I came across the whole Diane Jacob Silverman kind of idea of operator or interactor, because that's basically what we're saying. And that was back in 2010 or 11 or something, when it was basically telling us, look, guys, stop thinking that you're operating on people. You're not a surgeon. You're not fixing with your hands. Stop doing that. You're a facilitator. You're an interactor. You're working with that person. And basically this paper is saying that. And like you said, and a lot of people who are familiar with that will be nodding, going, yeah, we kind of know this. But my question to you guys is, and I'm sure you're aware of this as well, you're totally learned, and you know all of the times these principles have been challenged and solutions put in place. But the interesting point for me, and the fact that this paper is called A Modern Way to Teach as well as practice, is, why do you think there is this constant delay in therapists being able to grasp these principles and to actually, because as soon as you pause and go, oh, wow, it's not all about me. yeah, this person probably knows how to fix themselves better than me, so I should be sitting back and listening to them and then helping them achieve that way. What's the reason for it?
I think it takes, if I well remember some of the research, please guys, correct me if I'm wrong. I think it takes 14 years for evidence to seep into.
Yeah, but I read this.
Oh, I used to, you know, now it's different. I mean,
I read this and I went, oh yeah, makes sense. And it changed my practice. I was doing gait analysis on people and I was defining overpronation and supination and giving them the shoe that fitted in with that. And suddenly I thought, whoa, hold on. How can everybody in the world be categorized into 3 little sheep pens? That doesn't make sense. And once the coin drops, and this is as an educator myself, this is always the challenge, and I'm sure for all of you, making that coin drop, but not telling someone, not shouting at them, but eliciting it. So giving them a scenario where suddenly they go, oh, so that means, and then you think, job done. Let the snowball increase in size. I've rolled that pea down the hill. But how do we do that with therapists? Because we know therapists want to help others. We know they're not in it for the money. They're a fool if they think they're going to make a fortune out of it. They've got that altruism, they've got that empathy. But as educators, how do we get these messages across? The paper is a great start because hopefully people will read it, but maybe that in itself has got a little bit of a wall, because how many people are put off by the research and won't read it, or they just do the abstract, or they prefer to read it, you know? Go for it.
Can I take over from here?
Take it.
I'm Italian, I like to.
We know that, yeah.
Sorry about that, just in case people didn't.
You did so well in the football, so you may as well have your moment now. Yeah, go for it.
I already forgot, menopausal brain. Here we are. Our professions, you know, manual therapy professions, I love going back to where they came from. You know, it's difficult, it's different from medical professions. So we massage therapy, chiropractic, think about the bone setters. We come from, would you say, and I'm saying that with the utmost respect for all of the folklore, I don't know how you could call it in this. So our origin, you know, it's, would you call it that folklore? Like it's community-based, yeah, community-based. So it was people with a particular skill set that they, I mean, we even had chiropractic in ancient Egyptians, actually. So you started with that. So they perceived, they were born out of, especially massage therapy, out of people with particular skill set. So now instead we are moving somewhere in a very different realm, which is healthcare, where we, especially for us like soft tissue therapists and evidence-based practices as just come now, we are not as au fait with evidence and with research, because actually we're not a profession that, for us, that we are part often of the research for different reasons because of the complexity of research. So for one, you have where we're coming from, so that it's become much more of a, I would say, only recently that universities courses are, you know, in, for example, you know, sports therapy. Before it used to be a diploma, so there was not that educational background that you needed very much looking at evidence. So you even know what evidence was. You didn't even have the skill set to know what evidence was. So we already come from a very different perception of healthcare and what we do, because it's quite practical, and then on top of that is, and I'm very critical with that, governance. How can we have the same profession and have different syllabus or curriculum? How can we, especially non-regulated ones, sports therapy and sports and massage, how can we allow people to qualify and work with people autonomously and not have a certain understanding of what evidence is? So I always say, to me, the changes becomes, once you accept somebody in pain in your clinic, your responsibility changes. I don't care if you're level 3, level 4, level 5. You must be guided by evidence-informed practice. that is for me is the basic tenet of practice. And when that is not part of our governance, how can evidence and people feel comfortable to read papers? Secondly, the last, and then I'll let go, because the other one is, for us therapists, massage therapists or sports therapists, we very rarely are seen in research. So to me, the fact that I was a co-author there, it shows people, get yourself out there, get yourself involved. So don't wait for people to come and knock at your door. You know, the cliche, be the change you want to see, because that's what we need to do. Every single practitioner there has the responsibility to change the whole profession. So it's in our profession, I think is quite, you know, evidence-based practice, evidence-informed practice is as a history, and I think there are reasons why it's not easy to implement. And also the last, because
no, you already said that. You said the last twice. You can't do this. Yeah,
and because we are so ingrained in relying in experience. If I've done the same thing for 30 years and the client leave my room always happy for 30 years, what am I going to think? That I'm a great practitioner? Does not matter if the client has been coming to me for 30 years with the same pain, because my outcomes think, oh, the client is happy when he leaves my room. You see what I mean? We so rely on experience. We don't know how limited, you know, the bias that experience. So that's it.
That's fine. No. So yeah, we've got to, I mean, one of the things I want to pick up on that you said is like the regulation, for example. Okay, but fortunately, we have got two different professionals here who are both from careers that are regulated, which would suggest that all chiropractors are doing exactly the same thing, and it's all standardized and really productive. There's no dubious stuff in there, and all physios would be giving a great service. And because I'm being cynical, because I don't think that is the point. So let's address that first of all, the education. In theory, we can talk about humans having the confirmation bias and all of this, but if you've got the right educator in place who lets people know about this and lets them know that, you know, they're going to have to listen and practice these things and get over their natural tendencies to do this, then we should in theory be able to turn out these wonderful students. But I'm not even sure it is getting much better. But in your experience, Ken and Roger, can a change in education make this difference we need, or is there also problems with that?
You want to go, Roger?
Well, briefly, just from my point of view, yeah, I mean, we're regulated to a degree, but then within what sits under that, there's still a lot of variance. So, you know, there's standards we have to reach, but there's huge variance within that. And this is a really nice example, you know, the teaching of manual therapy. And going back to your earlier points about, is this modern and how do you get people to change and all that sort of business? Interestingly, the last sort of batch of strong review comments just before getting the sort of sign off for the publication of this was very much about, you know, this isn't that modern. We've all been doing it for years. And I thought that was a nice point, but this is a presentation of the literature, of the evidence, and as Anna Maria has been going on about, that's what's important. We couldn't find, we couldn't find any literature that says, yes, things have changed. People are doing this modern way now. We found evidence of a still very strong push towards traditional manual therapy. I mean, if you just look at books that have been published over the last five years and how specific they are about the different approaches to manual, you know, as interventions, and this specific type here and this specific type here, we haven't done a survey of all physiotherapy schools in the world to see to the extent of that difference, and that might be a nice piece of work, but there will be differences. So yeah, some of this common sense has been around a long time, but I think this paper has just been about another stepping stone, pulling it all together, and is, you know, which hasn't been done. There's a nice sort of thread of papers over the last few years that have all been a similar tone about musculoskeletal care and a shift in the way we approach people with musculoskeletal dysfunction. And I think this ties in with that batch of papers, and it's a zeitgeist at the moment. It's the way of thinking, but this paper is just about pulling together all that common sense and all that evidence and saying, look, and I mean, we were going to call it a new way to teach and practice manual therapy, and we got a bit of a sort of slap on the wrist from the journal reviewers and things saying it's not. So we sort of changed it to modern, but again, it's a bit of a provocative thing, saying, because I do appreciate that people have been practicing the way we propose for a while, but there is no evidence of that. So it's just pulling it all together and saying, yeah, come on, let's and like you say, behavior change is notoriously difficult, and it's multimodal and it's complex, and this is just another mode to try and settle in somebody's mind and wait for the magic to begin.
And what university are you at? Sorry, Ken, just to Roger, just for listeners who aren't aware, where are you?
Sorry, yeah, I did a really poor introduction earlier, didn't I? Where I neither mention my name or where I'm from. So yeah, hello everybody. My name is Roger Kerry. I'm at the University of Nottingham in the UK, in the middle of the UK. So that's where we are.
Fantastic. And your roles with regards to education and making this world a better place for healthcare?
So I'm the program lead for the BSc physiotherapy program, which is our regulated physiotherapy program.
And can you make changes?
Well, yeah,
power?
Yeah. Again, we have a staff body, we have a regulator, we're inserted in a wider school. There's certain changes can make certain changes. This is under our sort of responsibility, but that relies on getting 100% staff buy-in as well. As I say, I think we're in a really fortunate position, and this was generated by the core manual therapy teaching team anyway, so it's sort of, but you do get resistance about any sort of change like this, because again, like Anna Maria was saying, a lot is I've always taught it this way. It's same in teaching as in practice. I'm not going to take, I've been doing this very specific technique I've been showing kids for 30 years. I'm not going to change that. And then you say, well, the evidence doesn't really support that. And then there's conflict there. So, it's about people management. It's about behavioral change. It's about systems, governance, regulation. It's all of those things coming together. But yes, the idea is, as a program lead, should be able to influence the tone of our program, and the tone of our program at the University of Nottingham is very much in line with the evidence, and that
that's great. So, but I just like hearing you say it, because the obstacles are the same at trying to help or give help a patient realize they do need to do these exercises. Yes. It's the same barrier, isn't it? It's behavior change. It's them hearing what you're saying. And I think it's the same with making governing bodies and educators and teachers and all the team change as well. So I think that's one of the biggest obstacles. No, Anna Maria. I'm going to Ken now. Ken, are you in a situation where you can change the world of chiropractic? And what, if not, what are some of the barriers? What do you think are some of the walls that need chopping down in order to, because I'm hearing listeners are listening to this and I can hear them saying, oh, you can't just do evidence practice because there's a lot we do which isn't got, and I'm hearing all the objections, because naturally humans put up objections when they're a bit worried about handing over and they feel like, oh, if I can't do that, I've got nothing, sort of thing. So how do we help our listeners make them realize that you can change without throwing everything away?
Well, if I had the answer to that, I'd be driving a Ferrari. As you were asking that question the first time, I started writing a little list over here, and it just got longer and longer. And so there's history and tradition and professional and even emotional identity. There's confirmation bias. There's the fact that most chiropractors and osteopaths work in a solo practice. There are outside influences that change the perspective of students on their education. There's the inherent conflict in the fee-for-service model. So there are a whole bunch of issues. And there must be something also evolutionarily adaptive about saying, look, this has worked for me. I'm going to keep doing it the same way because it's worked for me. So why should I change it? Yeah. Right. And that gets into the confirmation bias aspect, which we've sort of touched on already. But so a couple of the hotter spots in that list, though, are the professional and emotional identity. You know, people come out of their training and they think, hey, I'm good to go now. And I'm going to, you know, hit this running and I'm just going to keep doing what I'm doing. And then they get into that area of the confirmation bias because all the patients seem happy. And so then that's a real inertial monster that needs to be overcome. Another area is solo practice. So the fact that, and I'm speaking mostly for chiropractors and osteopaths now, I'm actually really feeling the absence of an osteopath on the panel here. I wish Steve or David could have been here. But the solo practice has real dangers to it because it doesn't have the inherent governance structure like Anna Maria was talking about, that governance structure that exists in a hospital or a large multidisciplinary clinic. And so there aren't the checks and balances and the casual conversations. Hey, did you see this paper last week? Look at this new method. Hey, should we try this out? That sort of thing. It doesn't happen. CPD events and the CPD requirements from regulators try to address that to some degree, but their success with it is under scrutiny. I know because I'm scrutinizing it right now as one of the projects that I'm doing. And does CPD achieve what we think it achieves? And we're not really sure about that. One of the purposes that CPD serves, though, is to reassure the public, which is an important sort of side component of regulation. In solo practice, practitioners tend to diverge from the mainstream. They develop their own methods, and because they keep getting the confirmation, they can tend to stray further and further from even from what they were taught, let alone from what the new evidence is. Outside influences are something that we've seen in chiropractic and osteopathy courses with these technique gurus who develop their own sub-method of chiropractic or osteopathy, and then they go around promoting it. And a lot of these people can make quite a lot of money doing that by developing a technique and then selling seminars and books and things like that on it, and devices sometimes. And that influences and sometimes contradicts with what the educators are teaching to the students. And because there's a big psychological component to it, because a lot of times these are, well, they're mostly male, right? So they're guys who come in and they're really well dressed and they drive a nice car and they speak very authoritatively, very confidently, and they here's the answer to your problem. Here's how your practice can be easier and make you more money, and all your clients or patients will be happy, right? So that's a real challenge to overcome. And then there are also some traditionalists within the profession who denigrate evidence-based practice and the changes that are occurring over time because they are deeply and sincerely held believers in the traditional tenets of whichever profession it is. And so they, and I've seen this myself, they will tell the students, look, just get your degree and then come out and we'll teach you how to be a real chiropractor. And that's absolutely devastating to students because they think, what is all this education that I've learned? Is it really not worth much? It's just a piece of paper, and all the real information about how to be a chiropractor is out there somewhere else that they're hiding from me, you know, that sort of thing. So that's another challenge. And then the we never talk about the inherent conflict in the fee-for-service model. And I'm not saying that it corrupts everyone, but I do think there's an influence on decision-making on the part of the clinician when there's money involved, and particularly for new or struggling practitioners. You know, it can influence one way or the other, a visit here or there. Is it, is it really necessary? Is this next modality that, well, for instance, in the States, every modality is charged separately. So practitioners add on modalities because they can pump up the bill that way. And obviously, most practitioners do not do that, but it is an influence. It's an inherent conflict that may or may not be overcome depending on the individual practitioner. So there are many, many challenges in this realm. Why can't we make change? But I do have to say that I think change is happening, and I think that change is being led by the educational institutions. You know, people like Roger and his team that have the courage to stake out a new way, a new approach, and bring everybody on board, reluctant as some members may be to join that, and as happy as others may be. And then to write it all down and say, look, here's how we're doing it. And why aren't we all doing it this way? And then again, that transdisciplinary aspect of it, right? These are concepts that float above the individual disciplines of manual therapy and can be applied to all of them and can be accepted by the medical community and by the public because they make common sense and they fit with the evidence.
Excellent. That's a very good point. Just before we go to Anna Maria, yeah, the monetary system that a lot of clinics have had, and I think soft tissue therapists in particular in private practice will know that they've got a boss who's saying, right, make sure on average every patient you see is going to come back for 6 visits. And I remember I've always been very unsuccessful in clinics. I never got on with that idea, and I've also never had much money. But it is a problem because that is a more secure model. They think every patient 6 times because then we're guaranteed to get this. But in the long run, it's not, is it?
Only if you put a certain type of performance indicator. If your performance of your therapists are how many clients they see per month or how the retention rate, then yes, I argue is that you can run a very ethical, progressive and financially rewarding private practice. Even, you don't have to be NHS. So yes, in private practice, I do not see everybody. I don't see the people with socio-economical problems, or I do not see the people with social, determinants to health. I am sorry about that, but I am in private practice. Mm-hmm. So I know the people, and just because of the type of people that come to my clinic, I also know that I will have a certain type of outcomes. Okay, mm-hmm. So there is already different, but within that, there is no reason why it cannot be a ethical practice. Like for education, you have to have the right governance. You have to have the right manager, or if you're a solo clinic, a right professional association that gives you the right performance educators, the right performance kind of monitor. And one of our biggest role is to communicate to the clients they need, or that there is no need of, in this case, of manual therapy, and provide control through self-efficacy. But then if they choose to come back because they want that experience that is not related any more longer to pain, but they want the different experience as exposing themselves to variability of movement, or they want somebody to be part of their journey with osteoarthritis and they want to come back every month, I trust my client to make that choice. I have to give them plenty of information to make an informed choice. Mm-hmm. That you do not need to come and see me. There are other things that can make your pain better. But if you want to come and see me because of me, because of the environment, I am here for you. So, that's a completely different podcast, but I do think that being in private practice and be professional and ethical, they can work very well together. And that brings me to the point, Matt, which...
I just want to say one thing, because whilst you're talking about that, I'm going to set something for Ken and Roger to think about, because we're getting close to the hour now.
Yeah.
Whilst Anna Maria is giving some thoughts about education, Ken and Roger, I want to do what here on the Touch Matters podcast we call putting theory into practice. What do you want listeners, what can listeners take from this paper that they can actually start doing on Monday, Tuesday, whenever it is, after reading the paper? Because again, there's this problem of reading stuff and then you just keep doing the same thing. So what can they put into practice once they've gone and read this paper? Okay, we'll come back to that in a second. Okay, is that all right? Have a little think. Anna Maria, yes, education.
So I wanted to pick up on what Roger said about how difficult is behavior change within an education training environment, and all the difficulties. And for the students also, how difficult it is and how, you know, heartbreaking, like Ken said. But you see, behavior change is difficult. Or you see that actually our education system, or how we educate, our educational framework in FE is not fit for purpose any longer. We already and both vocationally and within university, I think we need to rehold the way the framework is. So we open to educate people to become responsible and good clinicians. And do we think that we are giving them enough kind of empowerment to actually make that decision making? Do we actually are problem solvers in our education, in FE education? I actually don't think we are. You know, we are very still structured in a quite a compartmentalized way, the way education still works in FE, that sometimes we don't have the time to actually stimulate that discussion-based, stimulate that problem-solving skill set, because actually this is what they need. They need to be critical thinkers. Once we can facilitate people to become, from clients to be critical thinkers and our students to be critical thinkers, that does not matter what CPD they go to, because then they will know how to evaluate and appraise that CPD. Sometimes I go to things that I even did a acupuncture course and I'm not into that, but I went
even
because I wanted to, yes, I wanted to learn. So I was able to evaluate because of my critical thinking. So we need courses which they have as basic ethos for clinicians to be problem solving and reasoning, and good problem solving reasoning are the basis as a skill set for life, but also as a skill set for you know, clinicians to become good clinicians. So especially for me in vocational, I am not supportive of level 3, level 4, level 5, because already people that come to us as adult learners, they already come with a different thinking approach. So we need to be skillful enough to merge all the learning. But in general, I think I am critical of the way we approach FE education, both at university and vocationally. I just have to say that, sorry.
That's fine. No, it's very important points. I think that is the crutch of the problem, isn't it? Because it hasn't really been working very well so far. And
correct. So is that it's difficult to get behavior change, or we are not communicating
exactly?
The
I mean, it wasn't.
We need them.
It wasn't Einstein. Yeah, it wasn't Einstein, but we'll say it was him who kind of said the definition of insanity is doing the same thing again and again and expecting the outcome to be different. It wasn't him, just in case anyone's going to email and say, oh, Einstein didn't say that. It's just another one of the things he said. But it's a good point, isn't it? We keep doing the same thing again and again and again, expecting it to change. It's not going to happen. So yeah, and that's what this paper is all about. That's why it's a modern way to teach and practice manual therapy. So I asked before, and this will apply for you as well, Anna Maria, putting theory into practice, because with so much CPD and stuff out there and podcasts and webinars and all this, it's very easy just to listen to them and enjoy them and then go back to clinic and do exactly the same thing. So what kind of practical things can people put into place? Ken or Roger, whoever's got something they'd like to say first. Yeah, what would you like readers of your paper to do?
I'll go so that we can give Roger the last word, since he is the first author here. So, first of all, Matt, I just want to thank you for giving me some time to think about it because I was really fumbled if I had to do it off the cuff. But I've written down a couple of things here, and it just I think what I would recommend, it ain't easy, but it's first introspection and then outreach. And what I mean by that is think back to when you graduated and even before that, what made you want to become a healthcare professional? Was it money or, was it helping people? And think about how your current practices align with keeping the best interests of the patient as the priority. In chiropractic, there's a tradition at many of the schools of taking an oath. It's sort of a modified Hippocratic oath. And I was involved in modernizing and rewriting the one that we used to give at Murdoch University in Australia, where I worked for a number of years. And I think it's a good one. It's a pledge. It's not an oath, because the oath has religious overtones, and we wanted to get away from that. So anyway, go find that and read that if you're interested. It's someday. Keith Simpson was the first author on that. So think about that pledge, and that pledge is all oriented towards patients. It's not oriented towards you. It's about how you can serve. And I don't know, I think in the world lately, we've lost a lot of the idea of service. We see it in self-serving government officials and other areas. We see it in the scandals that make the rag sheets every week. So reorient towards the patient, right? Introspection. And then reach out to other practitioners in your local area of different disciplines. Ask if you can come observe their practice. Say that you want to, buy them lunch, have a chat about how they approach a particular issue. If you've got a challenging patient, ask them what their approach would be. Go watch a surgeon do a few, procedures. Maybe start a journal club. I say that and I hear that coming out of my head, and I just think, man, that's the geek's approach, but I'm a geek, So there it is. Start a journal club, where you pick a paper every month or every 3 months and just talk about it. What does it mean? What did you get out of it? How did you interpret it? What's the difference? Those are my suggestions for how to take this paper and make it help you and your patients.
Excellent. And I think it's so healthy the way you listen to yourself. And this is what we should all be doing. Because for you, journal club, I'll be there every day. I love that. But for other people, and you recognize it and you felt embarrassed after you said it, it's not going to be the answer. It's the same for our patients. Go to the gym, hang out, stick a little vest on with gold on it. You feel great. Actually, no, I'm a runner. I don't really like that sort of thing. We've got to realize that what will work for you, the listener, is not going to work for everyone. So don't do what someone else does and think it's going to help. Find what works for you. So that's really good advice. And particularly, I love, I've written it down, introspection and outreach. It's powerful, Ken. Roger, oh no, Roger's going to have the last word, isn't he? So Anna Maria Mazzieri of the ST School, what would you like listeners of this podcast, after they've read the paper, hopefully we've given you enough of a reason to read the paper, how are they going to put plenty of theory in there into practice? What would you like them to do?
So if you're a student, ask your tutors, have you read this paper? If you are a tutor, make sure that this paper becomes part of your educational learning resource. If you are a clinician, ask if you treat physiotherapists, osteopatho, chiropractor, your colleagues within, shall we sit down and unpack this paper together? Or what, shall we, within the department, why, like I did with one of my clients, I said, bring this paper next to they do CPD, sessions, bring that to the next sessions. And we all have an opportunity, because it's so comprehensive, it's brilliant as a resource, just to get it across there.
Excellent.
And
That's
use
really
it as
cool.
it's a framework. It's a framework.
I think that's really useful as well. And as well as talking about empowerment for clinicians, as well as talking about empowerment for patients, it is a certain amount of empowerment for students as well. Have the confidence, like Anna Maria says, not to say, oh, have you read this? Oh, have you not? Oh, you thicko. I follow so-and-so and they're great and you haven't. I want my money back. Understand them. Not everybody has the time to read anything. So just kind of suggest it. Maybe print out a couple of copy and said, oh, I read this the other day. I found it really useful. Is it something you've done or you could read about, you know?
Beautifully written. It's just even the way it is, the word, even the way it flows is, I think is beautifully written.
It's definitely, it's not the sort of thing that's going to put someone off as soon as they start reading it. It's like, oh yeah, that makes sense. It is. It's very well written. Brilliant. Great advice there, Anna Maria. Thank you very much for that. Roger Kerry, what would you like putting theory into practice?
Yeah, well, thanks, Matt, and thanks to Ken and Anna Maria as well, and all of the above in terms of putting it into practice. It is about that reflection. It's about challenging your thoughts. I mean, the good thing is, the thing to do, taking theory to practice, is do less. You know, let go of some of this stuff. That's all we're saying. You know, again, back to the evidence. Manual therapy can be therapeutically effective, and that's independent of these three pillars of clinician-centred assessment of tissue, you know, patho-anatomical reasoning and tissue specificity. And it's not only that you don't need those things, it's that it's likely that those things are holding back the therapeutic effectiveness, and also holding back the you know, if you think about somebody being told, you're not going to be a good manual therapist until you've trained a bit more, until you've done this, until you've done this speciality, until you've done this specific technique. That's, you know, morally, that's holding back the amount of manual therapy that's being offered to the public. You know, it's violating a bioethical principle there, justice. You don't need that stuff. So reflect, think about what your role is in terms of, is your vocation about you, or is it about the people you serve? And the learning and application of manual therapy is just easier anyway. You know, we're still very skilled, it's still very safe, it's still very, you know, that's our model: safety, comfort, efficiency. It's not taking away a skill level. You still need to do that, but you don't need some of that old stuff to get the therapeutic effect. So reflect, think about your role, and let go of some baggage, man.
We'll edit that with the theme tune to Frozen, Let It Go. We'll put that in nicely there. Jim, if you can hear that, it'd be a beautiful ending.
I love the strap line. Is your vocation about you or about your client? Beautiful.
Yeah, it's pretty good. It's good. Right. Okay. So we have reached the end of this particular podcast. I feel, particular when Ken said, oh, it's a shame we haven't got an osteo here. I think that's one good reason maybe if we should do a follow-up. And also, I'd love people to listen to this, because whilst you guys are talking, as a podcast host, I'm always thinking, it looks like I'm listening to you, I do it very well, but actually I'm thinking of what all the questions people listening to the podcast are kind of going to come up with, the challenges, you know, and what they might come up with. But I think it would be nice to do this with maybe live with an audience, where we can get an audience of physios, osteos, sports, but any soft tissue practitioners who this kind of paper represents. We'll try and encourage people who attend that to have read the paper. That would be useful. So the questions will be relevant to the paper. There's an awful lot of answers that are in that paper, but maybe that would be good if we could do a second part, Touch Matters, with actual live audience to ask questions, because at the end of the day, that's the most important thing. That's why I like doing live ones, is because the questions asked by people are the real shop floor questions that people want to know. So we'll look into that. But for now, this has been an hour with 3 of the 12, I think, 12 fantastic authors for this paper, A Modern Way to Teach and Practice Manual Therapy. If you Google it, it will come up with a link to it, but we'll also make sure it's in the show notes along with links to other things that we've talked about, and also links to the individual speakers and guests who we've had on today, in case you want to follow them and get in contact with them. If you have enjoyed this podcast, then do please leave a review. That'd be great, because the reason I say that is just that's a massively important way of getting the information out and helping educate, because it just appears higher in Google. It's using the internet for a good way. The more you like it, the more it will appear in higher rankings and more people will hear it. So that's what we do, pray and hope that you do. It's very simple to do. I'd just like to say, Ken? 5 stars. Yeah. I said if you liked it. If you don't like it, then just go on your way. That's fine. And you're not, it's too much too soon for you. Don't go away too far, because you will be on our page one day. Maybe contact us one individually. But actually, in all seriousness, if you did find this was too challenging, it's put you into a state of a bit of kind of sadness or anger or frustration, which is very common if some of these ideas are new to you, then don't be angry for a while. But don't worry, we've all been through that. You know, we've all been in this game for an awful long time. We've been through all of those emotions, and we still are as things change. I mean, Roger, for example, wants to chat Chew as one of his students. So imagine the changes he's had to go through in his years of self-reflection. So
that's true.
It's true, isn't it? I've heard some fantastic stories about objections Jack's raised from the end of the lecture hall.
Was Jack?
Well, we won't go into that now, because
was Jack one of your students?
Yeah,
that's a separate podcast.
That's a separate podcast, especially the topic.
Can't wait for him to review this one.
X-rated.
Yeah, so thank you very much to the listener, especially for giving up your time, but also thank you to Ken Young. Thank you, Ken. And thank you, Roger Kerry. Thank you, Anna Maria Mazzieri, for joining us on Touch Matters. And hopefully you'll listen to this and be around for our second one. Take care.
Well, as usual, there is never enough time when we have so much more to say, isn't it?
That's very true. But as always, we would love to hear what you thought. So before you go, please remember to click subscribe for the Touch Matters podcast, and do leave us a review.
Ciao, ciao now, and see you next month.